Julie Mooney-Summers, who is an Associate Professor at Sydney Health Ethics at the University of Sydney. Her research focuses on the health of sexuality and gender diverse people, primarily related to tobacco, alcohol, and other substance use. And Dr. Rachel Deakin is a Research Associate with South Eastern Sydney Local Health District and the Faculty of Medicine and Health at the University of Sydney. She's an experienced clinical researcher in the drug and alcohol field and with other vulnerable populations. In collaboration with ACON, Julie and Rachel lead the longest running periodic survey of lesbian, bisexual and queer women's health in the world, SWASH. So I'll hand over to Julie and Rachel to present some of the findings from SWASH on alcohol and other drug use and mental health.
Thank you very much, Amy. I'd also like to acknowledge the Gadigal people of the Eora Nation, the traditional owners and knowledge gatherers and holders in the land where I am here in the University of Sydney, and also where SWASH generally has taken place. Rachel, do you want to share your screen with the presentation? While we're waiting for that, I also want to take a moment to thank Anna Barker for organising this series of seminars, which has been really great, but also just for all the work that she did for getting SWASH happening this year and being so super organised about it. And also to thank Anya and Luna and Afreen and Luca and Sophie, who all worked on the report this year. It was great having so many heads and perspectives involved with thinking about the data. So I'm not going to talk much about methods. I think most of you will know SWASH is a periodic survey, so it happens every 2 years. It's generally directed at women, specifically LBQ women. We have a small group of non-binary people who also participate in the survey. You can read a little bit about that if you want in the survey. Today we're going to talk about mostly about alcohol, tobacco and other drug use. I'm going to talk a bit about smoking and drinking, and then Rachel's going to pick up on drug use and then intersections with mental health. So we'll address questions at the end, if that's okay. Okay, thanks Rachel. So I guess a quick reminder about who participates in SWASH. So this year, which a data collection happened in February, so just really before COVID changed the world, we had a bumper year. So we had 1,588 participants in the survey, which is the most we've ever had, and obviously amazing response. You'll see there the breakdown by age, pretty consistent over time, just more of everybody, but pretty much the same kind of proportions in the age groups. The median age in SWASH is 32 and kind of has been 32 or 33 for most of its history. SWASH sample is highly educated. The majority are full-time employed, reasonable income. And I think as we're talking over the next little while, the thing to remember about that is well-educated, decent income, highly urbanized group, that we don't necessarily expect those kinds of things when we look at the kind of drug use that we're going to talk about. So that's something just to keep in mind. Other than that, a reasonable proportion of dependent kids. There's a mix there in terms of ethnicity. But I guess the last point to make there is that really the biggest bulk of the sample is coming from the city and the inner west in Sydney. So really SWASH speaks most strongly to community engaged LBQ women's experience in the kind of metropolitan Sydney. So that's worth keeping in mind. We would never claim that SWASH was in any way representative of all LBQ women in New South Wales or nationally. Okay, so let's talk about smoking, which is our good news story. You may have heard us talking before about the pretty dire rates of smoking in LBQ women that we've been showing from SWASH, which were pretty consistent for at least a decade. But things started to shift in 2018. So there was a marked drop from 30% current smokers in 2016 to 22% in 2018, which is a pretty impressive shift, and we were a bit concerned about whether that was real or not, so we kind of held our breath. But that's dropped down to 18% in 2020, so we're confident that we're capturing a real shift in the population, and that is absolutely good news given that we weren't seeing much of a change. It's worth noting that 18% of SWASH smoking is still higher than what we see among women in New South Wales in general, which is 13%, so still some work to do there. The other thing to notice here is that 63% of current smokers said they would like to quit or reduce their current level of smoking, which is very similar to when we asked this question in 2014. So clear indication there that there is that in terms of a desire to quit, that there's a willing population who are looking for support around their smoking. Less good news. So whilst we've seen a great decrease in smoking in the last couple of iterations, we're not necessarily seeing that continued trend among younger women. So smoking among younger women in 2016 was 42%, which was incredibly high given when we look at comparison populations. That dropped down to 24% in 2018, and you can imagine why we were a little bit apprehensive about whether that was real or not, because that's a pretty impressive public health miracle. So in 2020, it's remained at 24%. So we're confident that that's reflective of what's happening in our population, but it's clear that some work needs to be done here if still 24% of young LBQ women are taking up smoking. And if we look at that compared to New South Wales in general, so the same group, it's 11%, so much higher proportions. And as anybody who's involved in health promotion would know, it's much better to try and stop people starting smoking than it is to support people to quit smoking. So there's a real question for us around thinking in terms of whose job is it to look after kind of questions about younger LBQ women, given that their smoking on average will have started at about the age of 14. So we really need to think about who's going to do that work in terms of trying to support those women not to smoke. Okay, let's talk about alcohol. So 86% of SWASH participants reported that they use alcohol, which is significantly higher than women across all of New South Wales, although SWASH sample, of course, is younger and less ethnically diverse than New South Wales in general. So this is a breakdown of the proportions of people who are, how often people are drinking and whether they drink by age. And so the thing to notice here is firstly that no more than 10% are not drinking, that for the younger women, the most likely pattern of drinking is that people are drinking less than weekly. So they're not drinking that often. And you can see as age increases, that shifts to, by the time we're getting up to the 45 and plus, it's still less often than weekly is the most common response, but the second one is 1 to 2 days a week, and then 3 to 4 days a week, and then a significant proportion are drinking 5 or every day in the week. So we see a real age pattern there. So younger drinkers drink less often, but when we look at how much people drink when they do drink, then we see it going in the other direction. So younger drinkers are more likely to drink more, and the older drinkers are much more likely to drink 1 to 2 drinks. So what we're talking about here is younger drinkers drink less often, but they drink more when they drink. Older drinkers drinking more often, but they're drinking less, but it gets spread out. So one of the things to know here is the NHMRC, so the National Health and Medical Research Council, recommends that we drink no more than 2 standard drinks on any day in order to reduce the long-term risk of harm due to alcohol. And in our sample, just over half said that they exceeded that recommendation. So that's, I think it's, Rachel, if you can click the next one, I think it's 54% of the SWASH, 50% of the SWASH sample said that they were drinking more than 2 standard drinks. And that's twice the rate of what we see amongst women in New South Wales. So that's worth noticing. The second thing to notice there, Rachel, can you click the next one? As if we look at younger women, it gets a little bit closer together, but still young LBQ women are drinking much more often and are drinking much more than the women in general. National Health and Medical Research Council also talks about 4 standard drinks. So can you just go back a slide, Rachel, so just so that people can see what the numbers look like? Thank you. So more than 4 standard drinks is what we used to call binge drinking, and we're probably going to use that terminology. So when we ask people about how often do they drink 4 standard drinks or more, 16% of the sample said that they did, and 18% reported that of those 18% were doing that weekly or more often in the last 6 months. So that's quite a lot of what we would think about in terms of heavy drinking. And there's not great comparison data, unfortunately, in New South Wales in general for that, but it clearly demonstrates there's a particular pattern of heavier drinking than among LBQ women. Okay, so when we ask people about their concern around their alcohol use and its impacts, 21% of current drinkers said that in the last 12 months they had been concerned, which I think is actually quite a high proportion, and certainly demonstrates that there's an interest out there from LBQ women around thinking about their alcohol use. But only 5% of current drinkers said that they had sought help. So there's potentially an unmet need there that we might need to think about. I'll hand over to you, Rachel, for drugs.
Thank you, Julie. So, yes, I'm going to be talking about illicit drug use amongst our sample of women and non-binary people in Sydney. We have seen some significant increases in drug use, illicit drug use, over the last several iterations. They're not enormous in themselves, but they are there is an increase there. So when we ask about illicit drug use, we ask, have you used this substance in the last 6 months? So that's what we're reporting here. So you can see several red increased drug categories there: cannabis, ecstasy, cocaine. In fact, cocaine is now the second most used illicit substance, taking over ecstasy. The only substance that's decreased is amphetamines. There's also increases in the not so commonly used drugs, amyl, LSD, and ketamine. And overall, 54%, more than half of our sample, versus 13% of women nationally had used illicit drugs in the last 6 months. So that's a really big contrast there. I do want to, though, we have data from the National Drug Strategy Household Survey that monitors illicit drug use in sort of several year iterations, and these increases and decreases in certain drugs have sort of followed market change or drug market changes in Sydney. So there is more cocaine available, methamphetamines have decreased, and so forth. And if we look at, this is data from the Gay Community Periodic Survey from 2020. So it's a similar sort of inner Sydney urban sample of gay and bisexual men. And like our survey, most people are surveyed at Fair Day and other Mardi Gras events. And there's, for the main drug classes, there's actually similar use going on. 34% use cannabis, 25 ecstasy, and there's a similar, they've noted over years, a bit of an increase in cocaine use. The only big differences are in amyl use and Viagra. And yeah, there are reasons that that use is going on, we won't go into here. And so overall, the men answering the GCPS survey have reported using, 65% of them have reported using illicit drugs in the last 6 months. Then looking at support needs, so we asked people if they were concerned about their drug use or its impacts, and 11% of drug users indicated that they did have recent concern in the last 12 months about this, and 4% had recently sought help to manage their drug use. These aren't as big as with alcohol use, but there is still definitely a small but significant population in our sample who are concerned or are looking for help. Now, this slide here is a kind of approximate Venn diagram showing the overlap between drug use, binge drinking and smoking. Now, we're using here binge drinking more than 2 times in the last 6 months as a rough population indicator of what might be problematic drinking. So it's not a perfect marker, but just note the enormous overlap here between drug use in the last 6 months and binge drinking, and then also smoking. So out of this sample, it's about 1,400 people in this sample. You can see people who don't use any of these three are in the minority, 268 people. And a big overlap with smoking and both drug use and binge drinking in that sample of several hundred there. Now, looking at this big overlap between using these different substances, there's also a similar overlap between people who are concerned about their use or are seeking help, or in the case of smoking, would like to reduce or quit their smoking. In fact, amongst people who are concerned about their smoking, about half also are concerned about their drug use. So just sort of keep that sort of overlapping use and needs and concerns in mind over the next sort of several slides. So now we're looking at drug use and mental health. The next few slides are all presenting data by age category because we're reporting data from the Kessler-6 here. That's a marker of non-specific mental distress in the last 4 weeks. And even without looking at any other variables, there is a big difference with younger women in our sample much more likely to report high or very high mental distress in the last 4 weeks. So in these graphs, the green and yellow bars indicate low distress and medium distress, so pretty good, and the orange and red are high and very high distress. And you can see that the red and orange bars do drop down over the age groups. And so here within the age groups, we're comparing mental distress between those who have used drugs in the last 6 months and those who don't. And in each of the age categories, excepting the youngest, there is a more significant mental distress expressed by people in those that have used drugs than those that don't. We suspect within the youngest group, reported mental distress is so high that there probably is a ceiling effect. And so we don't see any difference there. Now, there are so many intersections that go between mental health and drug use. We're not saying by any means here that drug use therefore causes poor mental health, because it's a lot more complicated than that. And I think in the questions and panel discussion, we'll go into that a little bit more. Then having a look at binge drinking, so this is binge drinking 2 or more times in the last 6 months is a rough indicator of problematic drinking. We don't see such a difference between reported mental distress and whether people are binge drinking or not, except in the youngest age group, where those who report binge drinking 2 or more times in the last 6 months, more than 70% report high or very high mental distress, compared to 60% amongst those who do not. Then looking at sort of concern about substance use and their intersection with mental health. So those who have reported recent concern in the last 12 months about their drug use or alcohol use or its impacts, more than half, 57%, reported high or very high distress, and much higher than the 41% who did not have recent concerns about their drug use or their alcohol use. So that brings us to the end of the presentation part of this forum. Up here is the link for the full SWASH 2020 report, and I believe it will also be popped into the chat box to make it more easily accessible. So thank you. And now we'll move back to Amy to continue the forum.
Fantastic. Thank you both so much. So we'll move on to our panel discussion now, which will also include Julie and Rachel, but I'll introduce our other panelists. So we're joined by Dr. Lucy Watson, who's a Community Health Promotion Officer for ACON's Alcohol and Other Drugs and Mental Health Programs. She's also Editor-in-Chief of Archer Magazine and co-host of FBI Radio's LGBTQ+ news and culture program, Kings and Queens. They're not a medical doctor, but felt that completing a doctorate about LGBTQ Australians' attitudes towards celebrity culture was a suitably convoluted method of obtaining a gender-neutral title. And Sarah Etta holds a master's degree in social work from Fordham University. She has over 10 years of experience in the drug and alcohol sector in both non-government and government. Sarah identifies as queer and is a proud member and advocate for the gender and sexuality diverse community and is currently chair of the Gender and Sexuality Diverse AOD Worker Network. So thank you all for joining us. We've had a heap of questions come in with registrations, so I might start working through those, unless somebody in the audience has got a burning question. So I might start with you, Sarah. You mentioned soapbox in the lead up to this forum, and if ever there's a time, it's now. Why it's important for all services to collect data on gender and sexuality, and how does data collection help?
Thank you, Amy. I love to step on my soapbox formally. I think there's a lot of answers to that question, but the most important one that I try to carry on is that when we don't collect data on LGBTQ or even lesbian, bisexual, and queer women, we essentially erase ourselves. We're not considered. We can't reflect on data before. We can't move the data in different ways to go, lesbian women from the age of 40 to 45 have a hard time engaging in treatment at this age, and this is the reasons that they discharge. We can't respond to the needs that they have because we don't have any data to support it. Furthermore, we don't have any data to go to research places and go, look, this is a problem, and we need to, go back to the evidence and look at it, or even create it to respond to the need that's happening. Our health disparities are larger in comparison to the normal population or the heteronormative population, as Rachel and Julie explained. And when we don't do that and don't get into those conversations, even in mainstream services, then it's lost, it's gone. We're not even contending. And the other part of that is the hesitation from mainstream services, particularly to engage in asking the question, even just at that. The SWASH data is amazing, and kudos to Rachel and Julie about that. But mainstream services see us as well. And there's a weird elephant in the room, if you will, about asking that question. Is it taboo? Am I going to offend? And the research doesn't indicate that. And we want to be asked. We actually want the onus to be on mainstream services and other people to ask that question. So as a client coming to your service, we don't have to, assert ourselves in that way. We're already vulnerable in many other ways, and we want you all to engage and participate with us. And the research doesn't suggest or support that asking heterosexual people about their gender or cisgendered people about their gender and sexuality, that's harmful in any way or puts them off. So that's me soapbox.
Would anyone
Please
else
ask us.
Would anyone else on the panel like to add to that?
Yeah, I think if we don't collect that data from a community perspective as well, then we just don't have any of that information, the valuable information that we get from SWASH, for example, to be able to, do more primary prevention and stop it before it starts, be able to address these concerns before people are in treatment services down the line. If we have more information now about who's accessing treatment and why, then we can connect, their gender, their sexuality, and the context in which that all interplays with our drug and alcohol use and our mental health concerns and all of that. Then we can move that prevention space further as well.
And how it's naive to not think that our gender and sexuality isn't a major player in drug and alcohol use. Like, come on, please engage with us. Do you want me to go back on my soapbox?
I guess to draw a bit further on that, so NADA produced a resource on LGBTQ inclusivity for AO services. I think someone pop the link chat if you'd like to look at that. But the question, why is it important for services not only to ask clients about gender and sexuality, but to in fact initiate those conversations?
Because when you initiate those conversations as a mainstream service, you're doing a lot of things, but the most important thing you're saying is this matters to us. We want to talk to you about this. We are saying that this impacts your drug and alcohol use or your mental health concerns, and we're shifting the responsibility from the community to mainstream services, to any service, saying this also, it's best practice, it's research-based, it's evidence-based. We're tired of coming out. We've come out all of our lives, and if we're presenting to a service for drug and alcohol concerns or mental health concerns or both of those concerns, we're already part of another stigmatized population. We're already there, really vulnerable, like, hey, I need help. So participate in this with us and ask us those questions. There's guidelines there from NADA and ACON that have been developed that are really good. My only caveat to asking the question and being involved in that space is that when you ask the question, you need to be prepared to respond to the answer. So you need to, as a service or as an individual provider, know the research that's out there, know the best practice that's out there. It's not, you know, it's not going to break your brain or anything like that. But if you're going to ask the question and you're going to be in those spaces, which we welcome you, which we invite you to, which we encourage you to, we also need you to have an appropriate response to that. Not like, oh, drug use is drug use, and your sexuality sits outside of that, and we're just trying to fit you into mainstream services. No, what we're saying is this is a thing, and we want to talk about it, and this is how we're going to talk about it, and we're educated about it.
I thought I might just add, so I'm in a research group that's attached to a public drug and alcohol service in Sydney. And yeah, it's sad to say we don't consistently ask about gender identity and sexuality. I'm not going to go into all the problems. Public services is a big behemoth and relies on their medical information systems being set from above. Do understand that there are changes afoot in terms of having those forms that are asked by everyone at assessment. And a service where I work, I think is very friendly. Although I haven't been a client there, so I can't talk from personal experience.
Fair point.
Yeah. So yeah, it's not great, but yeah, there is some movement afoot, but I think there is still a lot of hesitation even within my service, which is in urban Sydney. There is still a lot of hesitation from staff around, but it's not they're coming for their drug use, not for this. But if these questions aren't asked, the questions help to set a tone, saying this is a safe place to talk about these issues as they are affecting your health, and you're allowed to talk about that. And then that's sort of the first step to starting to address people's concerns.
And just to piggyback on that, I think that people's hesitation in asking the question is well-intentioned. I don't think it comes from a deeply homophobic or transphobic space. I think it comes from an uncomfortable space, or like a well-intentioned, I don't see your gender and sexuality, I just see you, Sarah. But you can't see me without seeing my gender and sexuality. You can't see me without seeing me with how I move in the world, with microaggressions that I deal with on a day-to-day basis. Whilst they don't tear me down, they are a part of me and a part of my everyday life. And, I'm a privileged white woman. Imagine our clients who don't have those types of privileges and how that impacts them and how they navigate their world. It's our responsibility to be in those conversations first, to set the pace and the tone, as you said, Rachel, about this is important and we want to consider it, and we will, because it's best practice, and it's the most supportive thing for you.
Can I add to that? And I see Nick has asked a question about the major barriers, and I think that's kind of one of the things we're talking about here is if you know that your sexuality and gender is an important part of your identity and potentially relevant in your drug and alcohol use, then going to a service can be problematic if you're worrying about whether they're going to ask you about it or whether they're going to be comfortable about it. And I think it's important to remember that anybody who wants to access an AOD service already accesses healthcare in other places. So it's not like they're going in cold. They already have experiences of people being uncomfortable or not being sure how to ask about it or talk about it or not reacting in a positive way when it's raised. We talked last week at the forum last week about when we asked SWASH respondents about the last healthcare interaction they had and whether they felt that their gender and sexuality was dealt with respectfully. One of the things that was interesting was only 10% of people said that their sexuality and gender was not relevant in that interaction. And I think that says something really important to healthcare providers and AOD services here. Certainly if you look at SWASH, most people coming through the door feel it's relevant. And so I think your point, Sarah, about meeting people where they are and not making it then the onus on them to have to risk and kind of have that personal
Absolutely.
risk in saying, is it going to be okay for me to raise this, even though you can't possibly provide me with good clinical care if you don't know the context of my use or the context of my recovery, or the context of my support systems. So no one goes into an AOD service not already having potentially bad or at best neutral experiences with healthcare around sexuality and gender.
So I might ask the other people in the panel to come in on this question about what some of the major barriers are to LGBTQ women accessing services.
I think another major barrier could be a sort of mismatched perception of whether or not your drug or alcohol use is a problem. We're sort of seen in kind of talks with community this kind of, oh, well, everyone does it. Everyone drinks like this, right? Everyone I know smokes, so it can't be that much of a problem. And then we're seeing, no kind of campaigns or information-based campaigns that feature people that look like us. So we sort of you can kind of immediately look at that and go, oh, but that's for those types of people. I'm different. And especially if you kind of, are in that sort of, I guess, pre-contemplation phase where you're sort of finding ways to detach yourself from those people, then you can read yourself out of that narrative very easily in a lot of ways. So we kind of have to, give out that information and disseminate that information in ways that speaks directly to the heart of our communities, that looks like us, that has those conversations, that sort of changes this perception that, oh, but I'm not like that. I think there's a lot of kind of visibility that needs to be done and education around drug and alcohol use so that we can kind of demonstrate to the community that we do use these substances at rates much higher than the general population. And even if you go down to the pub with all of your queer mates and you all have 4 drinks, that's unusual in a general population setting, I suppose.
And there's some great data has come out of Melbourne asking women about their perception of alcohol use among their peers. And in general, people rate it much more highly. So they think that their peers drink more than they do. So I think there's a kind of a norm issue, which is, and there's some intervention going on in the US at the moment where they're actually looking to try and change people's perception of what normal drinking looks like in their peer group. And I think there's a really interesting question there about Jen asks this question about alcohol and drug use and smoking, it's part of who we are. It's part of what we do. It's part of how we connect. It's how we socialize. It's part of the ways in which we relate, as well as being one of the ways that we cope. And I think it's quite complicated. There isn't a single answer to why we see these rates. It's complicated. Unfortunately, most of the interventions don't deal with those complications. They deal with one thing. And so thinking about how do you support people to have different ways of coping with a homophobic and transphobic and sexist world, or to think about that, is that particular way of doing it which might be bad for us? What are the other ways of connecting? What are the other ways of socializing? I think Lucy's point about if people are in that pre-contemplation phase, how do you reassure them that they're not going to lose their entire support system if they stop using? Or, that's certainly something we've seen with smoking, is that women who no longer smoke have a different social network to women who currently are smoking. So we've done that work with ACON. So I think there's quite complicated stuff about the social and the psychological that we really need to think about very carefully when we're thinking about what kind of support we might offer here.
This is I suppose, related question, and we've sort of touched on it, but someone has asked in the registrations, how does stigma affect the way that sexuality and gender diverse women access and use support services?
I think it affects it massively. Even in the general population, women access support services or AAD treatment with greater health disparities, higher rates of suicide attempts, higher rate of suicidal ideation, sexually transmitted diseases, all of those things, all the things that you don't want to be worse at, you're worse at, and all the things that you're better at, you don't want to be better at. So that's happening in the general population. And when you add a layer of stigma about being LBQ, then it just complicates it that much more. So those people that are presenting, those women that are presenting, are even further behind the 8 ball. So that goes on to what Julie was talking about homophobia and transphobia, but it's also about sexism and how that's just another barrier for us to process and go through and manage. And how, as a service, we consider that with the normal general population, but then again with our population, and we need to be proactive. We have the data from SWASH, which is brilliant, and it says we need to be proactive, and we need to be lobbying the government and talking to all the people that will listen to us and the people that won't, that this is a thing and we need to get in there. Because if we don't, not to sound dramatic, it's the detriment of our community, and we as people are part of our community in these spaces need to use our privilege and our access to advocate.
Can I use my privilege to ask a question of the panel? So there's no new data here. So what we talked about today is the same data we had 2 years ago, is the same data as 4 years ago and 6 years ago and 8 years ago, 10 years ago. It is a great frustration that it's very difficult to get LBQ women's substance use seen. And I wonder how much of that is because what people think is they think women, and they think women don't use drugs and don't have a problem with alcohol. It's men who have those problems, so we don't need to talk about this or think about it. I don't know. I'm wondering how do we make these issues more visible? And that's it. How do we make these issues more visible?
Sure.
Talk about them. I don't know. I think that, with funding and stuff to be able to create these campaigns and to give that visibility to these issues, we, as you said, Julie, this is not new data. We've seen it before. And then we can kind of, if we have greater opportunities to start and have those conversations, earlier this year, we were going to launch at ACON Drink Limits, a sort of 8-week therapeutic group for women who are wanting to reduce or stop their alcohol consumption. And so we kind of were on the verge of launching a campaign. We had a bit of a mini campaign around that with some blog posts and everything, and a couple of blog posts that were women and some non-binary people as well, talking about the ways in which they drink and the way in which they reflect on their own drinking, and posting those blog posts alongside call outs to join the therapeutic group to reduce your drinking, within 2 days, we had about 30 people sign up to that group just from those blog posts. And so obviously with COVID, we had to press pause on that. And I think that kind of then captures a whole other different kettle of fish of, you know, what COVID's done to both support services, drug and alcohol use and patterns, and the ability to seek help if you need to, or how the context of use might have changed. But we're hoping to, you know, relaunch that Drink Limits campaign and program, at least in the alcohol space. We can see that once we start talking about it, people in the community are really responsive to it, which is really exciting. But it just needs to kind of keep happening in that sort of direction, I think, where we can, you know, the Smoke Free Still Fierce campaign from a few years ago, I still remember that. And I still remember the ad and the idea of going out and sitting out in front of the Red Rattler and just chewing on a carrot instead. Because I thought that ad was so perfect, right? Because it was like, you all go outside because the music's really loud inside and you just want to chat and connect to that person that you've been sort of vibing. So you go outside and you sit and you have a cigarette because it's the only quiet place you can chat. So if you all go outside, have a carrot stick, play with the chat box, or shave your finger hair. I think
whatever.
It comes back to, I think, you know, that's a perfect illustration of, I guess, community-driven and, you know, designed approaches. And someone, Sam's made the comment in the Q&A, which is not a question, but I think it actually does lend itself to a question, you know, that the biggest support group is our peer group, and people who use, ex-users, so people who are social users, and, you know, LGB, Narcotics Anonymous groups as well. Like what role does, I guess, you know, peer programs and people who are ex-users and users, you know, like how important is this, and how much are we drawing on this resource, and how much more could we do in that space? Anyone?
I think we could do so much in that space. I mean, peer workers and the peer-driven community is you know, really taking off at the moment, because they have a different understanding, and it doesn't negate clinicians and AOD workers and all of that brilliant stuff. But when you can connect to someone who's been where you've been, it's a different experience. NA is not for everyone. That is so true. And that's fine. And SMART isn't for everyone. And, you know, whatever modality of treatment isn't for everyone. But we need to acknowledge the variety of treatment. And in my opinion, in all of those varieties of treatment, we need to have lived experience represented. Not just lived experience of AOD users, but lived experience of, for this forum, LBQ lived experience people, because it adds a different layer of complexity, and it can't just be brushed aside. We're not, the function of NA or an LGBTQ NA isn't to funnel them into mainstream NA, because that's not the point. The point is, I want to come here to this meeting and feel safe in all areas of my life and feel confident that that's going to be delivered.
Yeah, I think sort of what we were saying before about, you know, having barriers to service with clinical services, not necessarily asking about gender or sexuality, or being sort of hesitant in that space. I think in that respect, having peer workers and peer support networks is so important, because it's someone that's just like you, that just gets it, and the sort of fear of stigma, whether that's real or perceived, goes away because it's someone that's just like you. And I think, you know, we've got peer-based sexualized drug use services sort of rolling out across ACON, particularly in the gay and bisexual men's space, but that kind of stuff can definitely happen in this space as well, because it's proven to be effective, and just having someone else like you that just gets it. I struggle to articulate that, but that's like, I just want someone to get it, man.
Really get it. Yeah.
Yeah. You know, see my flannelette shirt and go, oh yeah, I get you.
Right on. So Joseph's made a comment, which I think might lend itself to an interesting discussion as well, around, I guess, mainstream media sort of perceptions or like depictions of smoking, drinking, using substances, you know, in film and TV. His he's saying that he doesn't sort of think that that's as much of a thing in LBQ like women depictions, but how important does the panel kind of perceive that this issue is around, I guess, you know, still making this in film and TV or whatever a thing that's part of the identity and that's a cool thing or whatever?
Stereotypes are just so interesting, aren't they?
Thank you, Lucy.
Sort of, just this perception that LBQ women sit at home with their cats, watching reruns of Bunnings ads, and
nothing wrong with that.
Yeah, I mean, it sounds great. That's what I've got planned for tonight, actually. But yeah, and I don't know how we can kind of, because it was so interesting how, I mean, obviously in the data that was shown there with the periodic survey, there was somewhat higher drug use amongst gay men, but very high rates amongst both queer women and men. So it's certainly this sort of lingering and persistent stereotype that doesn't seem to reflect what is actually happening. But maybe we're all sitting at home with our cats and our flannelette shirts watching Bunnings ads and a beer. I don't know.
Could happen. I think the other thing to that is just take it back a bit further, is that the stereotypes and expectations placed on women in general are completely ridiculous and not achievable, really. And then you add again that extra layer of being LBQ, like we just, cards are stacked against us, you know what I mean? And we just need to realize, I mean, I'm striving. But it's more about realizing that that's not something to strive for.
Yeah, it's another $1 million question, I suppose. Someone's asked in the Regos what about the relationship in the SWASH data between mental health, alcohol and drug use and smoking. And obviously you sort of touched on that in the presentation, but what are your thoughts on, you know, how these things intersect and, you know, what opportunities, I guess, that poses for interventions or campaigns?
I think one of the things that comes out really strongly in our data is that campaigns need to deal with more than just a single issue. So if most of the people who are smoking are also the people who are using drugs, who are also the people who are binge drinking, then how effective is a campaign that just looks at smoking going to be? And I mean, I say that with all due respect to the Smoke Free Still Fierce campaign, because I think that was awesome. But I think that we're not talking about, someone asked the question about the contexts in which women are smoking, drinking or using drugs. And I think if we're thinking about those, the three different substances, a broad category of substances, that if all those things are happening for the same people, then we need to think really carefully about how we engage with conversations that deal with all of those things. And then when we add mental health to that picture, then again it says, well, can you really talk about smoking and treat it as if it's some kind of an individual choice issue? Can you really talk about drug use as if it's some kind of individual choice issue? You know, we really need to think about the social here, but also think about the kind of environmental triggers and what's the, you know, we've talked in the past, Rachel and I, about, you know, if you're asking young women to give up smoking, then potentially they're giving up the way that they access and connect with their community. And so you kind of, I think that's the same for alcohol and it's the same for drug use. We've kind of have real conversations about why people are using substances and what kind of mechanisms, what it is that they're looking for, and to have much more honest conversations about them, and also have really some quite difficult conversations about yes, alcohol and drug use, and to an extent less so I think for smoking, are incredibly normalized in our community, and we're probably not so good at talking about problematic use. And acknowledging, you know, Mardi Gras is still sponsored by an alcohol company. Is that okay? It wouldn't be okay for it to be sponsored by a tobacco company. So, you know, there's such a high level of normalization, but that we kind of have to talk about, I think, the intersecting issues.
Would anyone else like to add something to that?
What's important with that as well is how we measure success in the drug and alcohol space. And really this current shift that I'm really enjoying, that it's not about abstinence, it's about reduction in use, it's about, you know, increased visits to the GP, looking after your health stuff, increased, you know, mental health outcomes, that it's not this black or white thing, and the expectations for our community to be seen as successful isn't pure abstinence. That there needs to be some flexibility in how we conceptualize what is a meaningful intervention and how can we do that and how do we measure that, in the research kind of data space as well.
Sorry, go ahead.
Sorry, I was just going to say, I think sort of piggybacking off what you're both saying there as well is, we get so much social connection from these places where alcohol and drugs and tobacco are present and common. And then the social connection is sort of the thing that we seek to like improve our mental health. But then obviously compounding that with substance use can have negative impacts on our mental health. So it sort of ends up having a kind of, inverse effect of what we sort of intended maybe. And I think in speaking about Mardi Gras being still sponsored by an alcohol company, I was just thinking, earlier in the year, I tried to write like a blog post for Pivot Point, the ACON's AOD website, about what drug and alcohol-free event options were available for you at Mardi Gras. And it just became really difficult because actually there was basically alcohol present at almost every event because, there's like art gallery events, exhibition launches, which have free booze. There's Fair Day, which is not really focused on alcohol, but there's bars everywhere. Yeah. So I ended up having to kind of change the scope of the blog post to talk more about events where alcohol and drugs were not the focus, because actually solely alcohol and drug-free events were essentially non-existent. And I think that says a lot about how our communities can kind of find social connection and possibly the incredible importance of more drug and alcohol-free events so that we can have that social connection and the positive mental health effects of that without the possibility of the flip side, I suppose.
Yeah, I think that pretty well, Anne-Marie, hopefully you agree, kind of gets to what your question was asking around, how else can we think about, connection outside of alcohol and drug environments, early interventions around that and choices around, lifestyles rather than, the current kind of way that we think about it, which is reacting to a problem. I might just ask one last question that's come in with the registrations, which might be a topical one to close on. So given SWASH was collected this year just before COVID was a big issue, how has COVID-19 affected or changed sexuality and gender diverse women's alcohol use, drug use and smoking rates? And how has it impacted connection to community?
So a small question, nothing big there.
Come on.
Big. Get going.
Who knows? I think that's a really important and interesting question. There was a perception early on that that alcohol use was going to increase, and I don't know that that's been necessarily borne out in our communities. I know there's some research coming out now in terms of tracking alcohol use that showed that people who I know I won't be able to report it properly, so I won't say it. But in the general population, there's some data now coming out that's looking at alcohol use, and I know there's some studies looking at alcohol and drug use, which have also included sexuality and gender questions. So hopefully we will get some of that data. I don't know, Lucy or Sarah, anecdotally, if you have a sense of how things have changed.
I think, with no research behind us, one thing that I've had to be concerned about in COVID with particularly trans people or non-binary people, although it kind of falls outside the scope, is that they've been forced to be at home or be in a space where there's not gender affirming pronouns or their names being used, merely to keep themselves safe, and that has impacted on their drug use. And kind of considering the complexities that COVID presented for LBQ women and how that then translates onto drug and alcohol use and mental health, if that makes any sense. And I have no data to support that.
Yeah, I think that it really remains to be seen what the data will reflect. I remember there was a question in one of the SWASH surveys a couple of years ago that focused on the sort of context of use of drug use, and it was sort of seen that lots of queer women were using a lot more in the home, as well as at party spaces and stuff. So it's sort of with that in mind, there could be interesting implications there. I know that certainly we try to sort of frame COVID at the beginning of COVID as a good opportunity to, disconnect drinking habits from the pub. If you can't go to the pub anymore, here's a chance to make a change, switch up those habits a little bit. I'm not sure. Yeah. Like anecdotally sort of, and I think one other thing that's worth being on the lookout for, even if we don't yet have data to support it, but on the lookout for, particularly if we're heading into a Mardi Gras season where we can actually party. So that will remain to be seen, but, being mindful of things like reduced tolerance after a period of no use. So if people weren't actually using to the rates that they might typically, if they had access to community events, making sure that they're aware of the harms around lowered tolerance after a long period of lack of use, I suppose, is something else to look out for.
Well, as
That's
Jennifer,
a great point.
Yeah.
And anecdotally from my work, I've heard too that drug markets and availability have shifted a lot. There was lots of heroin doesn't really rate amongst the women who answer our survey, but it was more heroin than less, and then less methamphetamine. So also choices of and forms of drugs are going to change, and it might be higher or lower, and that's another thing to consider.
As Jennifer's observed, these are going to be great questions for the next iteration of SWASH, and Julie's looking very excited about that, I must say. It's been so great to see so much chat in the chat tonight. Thanks so much, everyone, for having such a lively discussion. It's been really, really good. I personally think it's been the best one so far. Really good chat. So thank you so much to all of our panelists, and thanks to everyone who came along tonight, and to those of you who've come to our previous seminars in this series as well. We really hope you've enjoyed them. You can find the SWASH reports on ACON's website at www.acon.org.au/SWASH. And if you have any questions, please get in touch with women@acon.org.au. Someone has asked Anna if these recordings will be made available. I'm just going to wait and see if Anna answers that question. Yes, so the recordings are going to be available. I'm not sure in what form, but if you want to find out more, make sure you, pop an email to ACON, follow their social channels. Obviously, they'll be updating as soon as they've got something to share. So thanks again to everyone for joining us. Stay safe, everyone, and take care.
Thank you, Amy. Thanks for being a great mistress of ceremonies.
Thanks, Amy.
Thank you
everyone.
all.
Thanks, everyone.
Bye.